Hello and welcome to Best of the Day from the 50th annual meeting of the American Society of Clinical Oncology, once again here in Chicago, Illinois. So this afternoon I'm sitting down with Dr. Ken Anderson from the Dana-Farber Cancer Institute, talking once again about plasma cell disorders and multiple myeloma. Ken, thanks once again to Best of the Day. You and I have been doing these for 10 years now.
It's been a unique privilege, honestly, to work together.
It's been fun.
And it's been fun at the same time. And I do think we've tried over the years, and we'll try again this year, to really highlight the progress. And what's remarkable for us is each year, for 10 years, we've been able to talk about huge excitement and impact on patient care.
It's been an amazing decade for multiple myeloma patients and docs.
It has, and I do want to thank you personally for all your efforts at helping for patients and caregivers alike to synthesize. Let's identify the take-home points. What is the real impact on the practice of medicine? You know, lots of information at a meeting like ASCO, very complicated, especially for the practitioners who are trying to keep up with many, many different cancers. You've really been a godsend in terms of really digesting it down to usable and important information for both the providers and the patients. So
Well, you're
a
very
hearty
nice.
thank you.
I appreciate that. And some of what Ken is saying, because it's not a secret that I am retiring at the end of June. So someone will take over. We don't know who yet, but maybe Ken. So let's talk about what's been going on. I know that one area that has been of great interest to you is the role of histone deacetylase inhibitors in multiple myeloma. And I know you have worked with many of them, vorinostat and the Isettalon drug, romidepsin, and a lot of these agents. But your associate, Paul Richardson, today presented one of the large trials with panobinostat, all of these Panorama 1, 2, and 3 trials. So this was Panorama 1, and this was Velcade Dex with or without panobinostat. So give us a little background on how HDAC inhibitors interact with proteasome inhibitors and why that combination seems to be synergistic, and how you see in the future the role of HDAC inhibitors in combination therapy in multiple myeloma.
Right. So it is a very exciting concept that was depicted in the Panorama trial today. The science behind it is to add a proteasome inhibitor, bortezomib, to block the proteasomal degradation of protein with an HDAC inhibitor, in this instance a broad HDAC inhibitor, panobinostat, given in this instance to block the alternative or agrosomal degradation of protein. So those are the only two ways cells have of degrading proteins, and the combination is synergistic in preclinical studies. So what my colleague Paul Richardson presented today was a very large randomized phase 3 trial in patients with relapsed myeloma whose disease is still sensitive to bortezomib, because the randomization was to bortezomib dex versus bortezomib dex with panobinostat added. And the reason it was of note is that there was a progression-free survival, the primary endpoint, advantage of 4 months in favor of the panobinostat bortezomib dex arm. It was 12 months versus 8 months. The response rate or the overall survival wasn't different in the two arms, but it was primarily progression-free survival. Now, that to me validates the concept of this dual blockade of proteasome degradation, of a protein degradation. There were, because it's a broad HDAC inhibitor, there were side effects. So about 2/3 of patients in that combination arm got low platelet count, about 1/3 got low white blood cell count, and about 36% of the patients actually had to discontinue therapy because of the side effects. But I mention that because, as you have already alluded, the concept of an HDAC inhibitor coming into our armamentarium in myeloma is very exciting. But the hope is that the broad-acting HDAC inhibitor, like panobinostat, can now be incorporated perhaps with different doses and schedules to try to make a better side effect profile. In addition, I've been very involved, as have others, in trying to have more selective HDAC inhibitors with the same view that you could potentially get the benefits that were demonstrated here, maybe even more, and avoid the side effects. In the panobinostat trial, the dose and schedule of panobinostat was every other day. It's an oral agent, 3 times a week for 2 weeks, so that the patients only got 6 doses in a cycle. We're hoping with the more selective and user-friendly HDACs to be able to get many more daily doses and to try to exploit this very exciting preclinical data.
So I know the Isettalon agent that you've been investigating primarily targets HDAC6, and is that the most important histone deacetylase inhibitors as far as the agrosome is concerned?
Yes, it is. The HDAC6, as it turns out, binds to the protein, the ubiquitinated misfolded protein on the one hand, and it binds to the dynein motility complex on the other. So it shuttles, the HDAC6 serves as a shuttle to bring the garbage, if you will, to the agrosome for degradation. So genetic knockdown or now pharmacologic knockdown or blockade of HDAC6 can really quite effectively block that other pathway.
So one of the HDAC inhibitors that is actually on the market and available and approved for cutaneous T-cell lymphoma is vorinostat. And Dr. Wiesel presented an early study adding an HDAC inhibitor to a triplet of lenalidomide, dex, and a proteasome inhibitor, the newer agent carfilzomib. So is this quadruplet regimen, is this something that looks like it has potential for the future?
I think it does. Whether these are the exact drugs again, I'm not sure, but the idea of adding an immunomodulatory drug to a proteasome inhibitor, we've talked of many times, lots of rationale for that. And adding an HDAC inhibitor to the proteasome inhibitor we just talked about for the purpose of protein degradation blockade, it turns out there are different reasons for adding HDAC inhibitors to the immunomodulatory drugs. For example, blocking the oncogene c-Myc is a very potent activity of the HDAC inhibitor plus IMiDs. Suffice it to say that that's a good team. And so what Dr. Wiesel reported here was carfilzomib, the new proteasome inhibitor, lenalidomide, dexamethasone, and the older, more broad HDAC inhibitor called vorinostat. And the good news there was, in fact, there was a 53% response rate in relapse refractory myeloma.
That's pretty impressive.
It's good. The side effect profile, though, again, because of the broad, not the carfilzomib or the lenalidomide dex, but because of the broad HDAC inhibitor, is still an issue in terms of low blood counts, etc. Both lenalidomide and vorinostat, for example, will lower the platelet count. So I think the concept is right. My hope is, honestly, in the future we'll have more selective HDAC inhibitors, but we'll also have an oral proteasome inhibitor, MLN9708. So we could add oral proteasome inhibitor, IMiDs, lenalidomide, dexamethasone, and perhaps the
entirely oral
HDAC6 inhibitor.
Quadruplet, yeah, that'll be interesting. Well, over the years, you and I have talked about the fact that myeloma docs have been looking for a myeloma rituximab. And we've talked about elotuzumab, which targets CS1 or SLAM7. And then more recently, there have been a number of drugs targeting CD38, which is broadly expressed on plasma cells. And there were several abstracts at this year's meeting with the two most prominent agents, daratumumab and the Sanofi drug SAR 650984, I think. So how are those drugs coming along? There were single agent presentations and then combinations with lenalidomide and dexamethasone.
Yeah, so immune therapies at ASCO this year are the most red-hot topic, right?
Yeah.
That includes solid tumors, but we in the blood cancers are a little bit behind, but we're catching up. And so the antibodies to CD38 are an example. we in myeloma have already another antibody called elotuzumab that targets a different target, CS1 or SLAMF7, and it's already in phase 3 clinical trials together with lenalidomide dexamethasone demonstrating remarkable activity even in genetically adverse myeloma.
But elotuzumab doesn't have much in the way of single agent activity, but it works well with the IMiDs and I guess with proteasome inhibitors as well.
Right, that's exactly right. So it's remarkable that it had very little single agent activity, but together with lenalidomide dexamethasone, remarkable. In contrast, or some similarity, the lenalidomide dex is a very good partner for these CD38 antibodies as well. However, distinct from the elotuzumab, these CD38 antibodies, the daratumumab and the SAR drugs you mentioned, actually have single agent activity. Now, the difference, I want to highlight one quick difference. The CD38, as you said, is broadly expressed. We recognized it 30 years ago on myeloma, as well as on activated immune cells of various kinds and endothelial cells. So it's not as selective as the elotuzumab directed at SLAMF7. Be that as it may, it seems to have a favorable side effect profile so far. And in the studies reported at ASCO this year, which were primarily updates, but there was single agent activity for both the daratumumab and the SAR drug ranging from 25% to 40%, which in each case, when you added lenalidomide dexamethasone, went up as high as 60 to 70%, so a marked augmentation when you added lenalidomide dex. The other thing that was reported here from the Netherlands actually was for daratumumab, one of these CD38 antibodies, was a dose study where they compared 8 milligrams per kilogram to 16 milligrams per kilogram. And in fact, the 16 milligram per kilogram dose was more effective. I think it was a 48% response rate as a single agent. So these are very exciting, and I think want to highlight again, they work apparently even in the p53 deleted relapsed refractory myeloma cells. So this is a major...
Del17Ps.
Absolutely.
Right.
Very exciting.
So since CD38 is expressed on other cells besides just the plasma cell, is there much in the way of off-target adverse events?
So far, and I must tell you, surprising to me at least, there hasn't been much toxicity. But the things we need to be cognizant, especially with more chronic use, that number one, antibody levels tend to build up with time. So we need to watch here that we don't have accumulation of antibody. Secondly, what would we expect for toxicities? Well, with chronic use, you might expect to see a low platelet count because CD38's on platelets. You might see dropout of other blood lineages because CD38 is on 1/2 of all the hematopoietic progenitors. But even more importantly, CD38's on endothelial cells throughout the body, so potential clotting issues or other things. Now, I'm not saying that there have been any of those observed. There have not. The final point I'll mention is that it's on activated immune cells, so that when somebody tries to mount an immune response to infection, all of those immune cells will strongly express CD38. So I think, although I'm hugely optimistic, as you know, the Red Sox fan is always present in me.
The Red Sox have been struggling this year.
Well, we lost 10, but we've won 5.
Oh,
so,
good.
I'm not sure which trend is the good one, but or the persistent one. But in any event, back to the CD38 story, I think we're very excited about it, and we just wanted to urge that we want to watch with time and make sure there's not chronic side effects.
So is there a limit, do you think, that needs to be put on the number of cycles of therapy that patients are going to get?
I think it remains to be seen. The two antibodies are being tested in slightly different ways. So the daratumumab is being tested weekly for 8 weeks, and then every other week for 8 doses, and then monthly if there's persistent benefit. On contrast, the SAR drug, also targeting CD38, is being given every other week. So it's being given less commonly, frankly, we don't know which of the doses is better. And it's important to remember, you say, well, how could we have room for two different CD38 antibodies? Well, they're directed against different epitopes, so they could very well have a different spectrum of clinical benefit too.
Absolutely. Well, we've got 3 different anti-CD20 antibodies, so with different epitopes. So I'm sure there's going to be room for. We'll just have to watch these and make sure that there aren't longer-term unfortunate events that take place. So finally, let me just ask you about one of the studies with Pomalidomide. Pomalidomide is now approved and available, and it's also being combined. But there was a presentation combining it with Velcade Dex, sort of a PVD versus RVD. So does this look good? Is this going to be a replacement for the RVD regimen? We've already got the CRD out there with carfilzomib potentially replacing bortezomib. Are we going to replace lenalidomide as well?
I think that the study was, again, by Paul Richardson, where pomalidomide low-dose dex was combined. The pomalidomide low-dose dex, as you know, is approved for relapsed myeloma treatment with bortezomib. And so the principle of an IMiD plus a proteasome inhibitor has been established, as you've said, with lenalidomide bortezomib dex, with carfilzomib bortezomib dex, and with the oral one, ixazomib lenalidomide dex. But what pomalidomide dex is now used for, as you know, is relapsed myeloma treatment. So what Paul Richardson was doing with colleagues is trying to use a dose escalation phase 1-2 trial to figure out what is the best combination of, in this example, bortezomib with pomalidomide low-dose dex. And it was the usual dose of pomalidomide, which is 4 milligrams orally for 3 weeks out of 4 with dex, together with full-dose bortezomib, 1.3 milligram per meter squared. And what he showed was in patients with relapsed myeloma, that combination at the established dose achieved a response rate of 67% in relapsed myeloma. So I think what it, so what it tells you is that we're using triplets for newly diagnosed patients, including an IMiD and a proteasome inhibitor. And in the relapse setting, we're likely going to be using, similarly, triplets with
were these patients who were len refractory?
There were some that were len refractory. They had relapsed myeloma. Now, in today's world, lenalidomide has largely moved up front. So yes, there were a significant fraction that were len refractory.
Very good. Well, it's impressive. Every year there's more and more interesting data coming out, and still a lot of novel agents. I know there's even antibody drug conjugates being looked at in multiple myeloma. So I'm sure in the years to come there will be even more interesting stories.
Yes, we've been very blessed over, as we've just said, the last decade. Think of the progress we've been privileged to watch. Think of the patients that have been helped. And again, I do want to return and just thank you, very heartfelt and genuine thank you. You've really educated patients and caregivers, and Lord knows countless patients are doing better because of your efforts. So,
you're very nice.
Thank you so much.
Thank you so much, Ken. All right,
Okay.
And thanks to all of you for watching this segment of Best of the Day. There is much more to come this year from the 50th annual ASCO meeting. We still have breast cancer, melanoma, lung cancer, GI malignancy. So stick with us, and we really enjoy bringing you even more information. Thanks again.